let me first thank Emirates Dermatology Society and Dr. Fatman in particular for giving me an opportunity to talk about a profound condition. Let me say that in a single sentence, this is probably going to be the largest challenge for dermatologists worldwide. I'm not just saying about myself or about India or about the subcontinent. Believe me, you are going to face the largest problem of your life with this condition. So, you're already facing it. So, dermatophytosis and the challenges posed by the new pandemic, literally that's in inverted commas because we haven't as yet declared it as a pandemic. But of course, this is spread worldwide and it's a multi-drug resistant strain of Tinea glabrosa. Why Tinea glabrosa? The interesting thing is that this is actually a term coined fairly recently. It has its defects. Glabrous skin means skin without hair much. But still, by definition, Tinea glabrosa includes Tinea corporis, Tinea cruris, and Tinea facial. This is just an accepted definition. But Trichophyton indotineae sort of evolves so rapidly that even this definition no longer holds good. It affects the palms, it affects the nails, it even started affecting the nails of the toe. The speed with which it is evolving is so rapid that we humans are unable to catch up with it. So what is this? What is Trichophyton indotineae? How does it present clinically? What is the epidemiology? Why is it that it has emerged? When should we suspect it? How do we confirm it? And how should we treat it? So in other words, what, why, how, when of Trichophyton indotineae. This is going to be my core message. Of course, these questions have headings where an article published in Dermatology World. These sentences are not my own and I have acknowledged the references. But let me start by my own story. Tinea glabrosa has been confronting us for many years. When I came to Dubai 20 years ago, I came as an assistant professor from one of the largest dermatology teaching institutes in India. And mycology and management of fungal infections was very common for us. And of course, dermatophytosis was very common. And I would say that it was relatively easy to treat, easy to recognize. We knew that there were entities like Tinea incognito and steroid modified Tinea, but they were not that common. But 10 years down the line after I came to Dubai, I started noticing in my clinic that the traditional treatments which we used to use were no longer working. Surprisingly, we were able to recognize this clinically even before many publications started. And I would say that terbinafine, which was touted as being the #1 drug, fungicidal, not fungistatic, all these terms became irrelevant. Fungicidal or fungistatic does not matter. Terbinafine does not work. And we tried it. And believe me, the industry tried to teach us that, okay, you give double dose. You give it for a longer period of time. This is what we tried initially, and I believe many of the new adapters are being taught this. Believe me, it does not work. Whatever you do, terbinafine does not work. Whether it's oral or topical. Very rarely does it work. Therefore, we are obviously facing a challenge. And the challenge has evolved even over the last 10 years. About 3 years ago, I was fortunate enough to collaborate with Professor Shyam Verma, and 70 samples I took personally from my own clinic, which were sent to Professor Petronenov, and a lot of tests were done. In fact, Silpi Umari's PhD thesis, many of my own samples are there in the thesis. And we discovered that nearly 94% of the cases, out of the 70, were a strain of Trichophyton ventagrophytus complex or interdigitate, which was called type 8, which was highly terbinafine resistant. And surprisingly, even itraconazole in the conventional doses that we were using were no longer effective. It looked as if it was learning about itraconazole, and soon we would be facing a huge challenge because itraconazole might no longer work. So what are we dealing with? And even the clinical presentation was very strange. One of the first things we noticed was the huge number of patients with facial lesions. Any inflammation of the face, any inflammation of the ear turned out to be more commonly due to dermatophytosis. Even rosacea-like presentations were common. Therefore, it was not just tinea cruris or corporis, but tinea cruris, corporis and faciae. The clinical presentation was something which was rapidly advancing. The moment you see a patient, you see almost the entire skin involved, but we understand that it moves very rapidly. Within a matter of months, it spreads all over. And secondary infection rate, the number of persons infected within the family is so huge that it was astonishing. We knew that the earlier Trichophyton rubrum, used to infect a person, and there seemed to be a genetic predisposition to get it. A spouse very rarely got it. The children may get it because they have a genetic relationship. But this is not like that. Entire family, we feel that once a person gets infected, almost everybody gets infected, and within months. In my own clinic, I would say that if I see 50 patients in a day, 25 patients have dermatophytosis. The epidemiology is not yet clear because we don't have exact figures, but clearly it's one of the largest problems we are facing. So what is this Trichophyton indotineae? Let's introduce this new beast. This beast is a dermatophytosis which is extensive, recalcitrant, frequently resistant to terbinafine and spreading worldwide. And the interesting thing is, it always seems to present with cutaneous signs of steroid abuse. You can see the skin atrophy, you can see the hypopigmentation, and surprisingly, it seems to affect even the glans penis. Even in women, it affects the external genitalia, which was not a feature very commonly with the rubrum. Therefore, we are looking at a beast which behaves quite differently. So what is this Trichophyton indotineae? The word Trichophyton indotineae was coined fairly recently, 2020, by Cano et al., who isolated two highly terbinafine resistant strains of Trichophyton indotineae-like strains in Japan. They do KOH, they do culture, and then they do DNA analysis, and then once you have a DNA map, you match it with the DNA maps of established strains, and when they did it, they said that this is 94% like Trichophyton interrophytus. It is 98% like Trichophyton interdigitale, but it is 100% like the strains of Trichophyton interdigitale type 8 found in the subcontinent. Therefore, we recognize that this is a genetic species of its own, which has characteristic mycological and characteristic clinical presentations. So mycologically it is different from Venterophytos and interdigitale. Clinically also it behaves differently. So it's clearly a different new species. Of course, in 2016 itself we had recognized it in India, and I would say that Trichophyton interdigitale type 8 was well known and terbinafine resistance was well known. And of course it became very big issue once the missense mutations, that is viral epoxidase gene mutations which render high terbinafine resistance, was recognized. 2 cases were reported from the United States. When they reported, we had seen 1,000 cases from the United States already. The Indian subcontinent has any number of publications of people of Indian origin and even American people traveling from the US to India and who were demonstrated to have Trichophyton interdigitale type 8. Therefore, the 2 publications which were published in the US came on very late. Now, a little bit about the mycology. We all know that fungi belong to a new kingdom. They are not plants, they are not animals, they have chitin in their walls, they have some characteristics of plants, but most of their characteristics are that of animals, They have ergosterol in their cell membrane, and they do not move like plants. They seem to grow in the soil like plants. They do form spores which are distributed by the air very easily. Some of the spores are flagellated, but by and large they do not move on their own. These are all interesting things. The taxonomy of mycology was based on cultural characteristics, sexual and asexual phases. Many of the dermatophytes do not have recognized sexual phase. That is because we don't look properly. You see the orange bar and the green bar. The orange and the green one represent the sexual phase. Trichophyton mentagrophytus originated in the soil. It was originally geophilic. It hopped on to rabbits. It had cycles which repeated from the soil to the animal, etc., till it adapted to a zoophilic life. Even then, the sexual reproduction can be demonstrated. Once this zoophilic state happened, slowly it adapted and it became anthropophilic. When it became anthropophilic, for a short time you can see the sexual phase, but the sexual reproduction stops. And it's now totally anthropophilized, and you have only asexual reproduction, and you have the new beast which has developed, which is Trichophyton indotineae. Obviously, this is all Darwinian, and the pressures of natural selection, the preservation of favored races in the struggle for life. So this is the obvious answer. How does Trichophyton indotineae infection present clinically? It presents as Tinea cruris first, corporis, and facial. This is the main take-home message. It is pretty recognizable clinically itself. You don't need a DNA analysis to tell you that this is Trichophyton indotineae, because the presentation is very characteristic clinically itself, and we will come to that soon. But invariably we find signs of steroid abuse. So red scrotum syndrome, stray skin atrophy, hypopigmentation, telangiectasia, all signs of abuse of topical corticosteroids are commonly found in this condition. It spreads very rapidly and continuously. Cruris, wrist, trunk, face, so by continuous spread, by touch. And it spreads from person to person pretty easily. And fingernail onychomycosis is common. Therefore, obviously, it is something that spreads by contamination. Just a representation to show you that it is quite extensive. Already you can see signs of steroid abuse. The epidemiology again is very interesting. Highly unreliable data, because we really don't know the exact epidemiology. But 20 to 25% of global population is affected. It's huge. Almost all the countries in the world. Why? Why has this happened? It's a matter of speculation, and I would say that it's an infection, the agent, the host, and the environment. What happened to the environment? Global warming, a niche which actually permits this natural selection process of a beast which spreads rapidly, which is Trichophyton indotineae. What about the host? We facilitated it by using topical corticosteroids, fixed drug combinations of topical corticosteroids with antifungals and antimicrobials indiscriminately, and this resulted in topical immunosuppression or occurrence of immune suppressed districts in the skin. Commonly the groin, where once you put a topical steroids, there is a suppression of both innate and adaptive mechanisms. We know the importance of immune reactions in warding off dermatophytosis, but the indiscriminate use of immune suppressing agents created a niche where this fungus started evolving to overcome all this, and of course the agent. The agent adapted. It is no longer the old beast. It's a new species. New species means there is no mating between Trichophyton indotineae and the other species. Obviously, it's an independent species of its own accord. And the agent has changed, The post has changed, the environment has changed. How can we prove all this? There is enough evidence to show that topical corticosteroids and combination topical corticosteroids are probably one of the most important factors in the problem that we are facing. Of course, just images about the easiest thing for us to do. You can see the branching hyphae and the arthrospores. The interesting thing about this identification process is mycology labs, we don't need to culture it nowadays. See, when you culture it, you cannot clearly differentiate even after culture that this is whether this is Metamorphosis, interdigital or indotineae. Even the pigmentation in the reverse is not characteristic. Biochemical reactions wise, the urease test is negative even after 7 days and 14 days with Trichophyton, indotineae, but then they are not very diagnostic always. And the hair penetration test, Trichophyton, indotineae doesn't penetrate hair. But the most important thing is genomic sequencing, and with genomic sequencing we actually diagnose it perfectly. And I would say that this is actually a website. If you connect to cdc.gov, they help you set up a lab. I would say that dermatophytosis has given us probably the largest opportunity for research. So whether it is clinical, whether it is epidemiological, whether it is diagnostics, we are actually given a box full of opportunities. And the culture, the lactophenol cotton blue test, all these do not confirm the species. It is the internal transcriber sequencing of the genome which is important. This is from the IADVL publication which showed the relevance of all the tests. Average bedside test, very important. Tinea incognito and steroid modified Tineas are very common. Therefore, it is very important for us to do this test. Histopathology, not very important unless you have Major's granuloma or a little deeper dermatophytosis. When it comes to isolation by culture, it's not that important nowadays. When it comes to identification of the species with the DNA methods, that is probably the most important. Of course, you do have proteomic signature, and you can use spectrometry to analyze the proteomics to identify the species, but that turned out to be not as exciting as initially it was touted to be, and it is the DNA analysis which is more important. Of course, antifungal sensitivity testing is important, but that is for research labs. CDC, some of my samples are with CDC right now, frankly speaking. They are doing tests, and even itraconazole, the MIC has gone. And I would say that identification of mutation by real-time PCR is possible. So it is very important for us and for the Emirates Dermatology Society to set up labs which have this kind of DNA testing for research purpose and for diagnostics. How do we treat? Currently, the drug of choice is itraconazole. The second line agents are fluconazole and bezafiolate. Topically, lureconazole and voriconazole creams. Multifosin anti-leishmanial agent has been touted. Of course, general measures are very important. For lack of time, I won't go into all that. We need to know in and out of itraconazole. Why? Everybody is using it. Everybody is using it in off-label doses. Everybody is using it in toxic doses. We are going to see a huge number of patients who get side effects with itraconazole. Therefore, if at all you need to know everything about any drug currently, it is itraconazole. So itraconazole is a first generation triazole water soluble, broad spectrum antifungal, and it inhibits ergosterol synthesis. So lanosterol must undergo a 14 alpha demethylation to become ergosterol, and itraconazole blocks this reaction by interacting with the fungal 14 alpha dimethylase. You note the highlight on the fungal. It is pretty specific for fungal 14 alpha dimethylase, so it spares the human tissue. And this is a depiction showing that itraconazole blocks lanosterol 14 alpha dimethylase, prevents lanosterol becoming ergosterol, the cell membrane becomes porous, vulnerable, it is supposed to have a fungistatic effect, rarely fungicidal, but as of now, it is probably the most effective agent. What do we need to know? We need to know that it is metabolized by cytochrome P450. That means drug interactions we need to be aware of. Certain drugs might be enhanced, certain drugs might be inhibited, and half-life is between 34 to 42 hours. When you suddenly withdraw a patient from itraconazole, there may be a side effect not only with itraconazole but the other medications they are taking. And dosage, this is the billion-dollar question. 100 mg twice a day, 6 weeks, 12 weeks. Believe me, I have a patient who has taken for 30 years. 30 years. And it's still not cured. Still not gone. Luckily, his liver is still okay. Up and down, he has been taking. Up and down, he has been taking. Of course, I didn't give you for 30 years. But the story is that the duration of treatment is up for grabs. And I would say that if you look at definitions of what is clinical cure, what is mycological cure, all these definitions are outdated. You have the opportunity of making Delphi consensus for almost anything in Trichophyton indotineae, believe me. And the capsule and the oral solution which is available are not bioequivalent. Even the generic brands of itraconazole do not have similar effect. It contains pellets inside. The number of pellets and the size of the pellets determine the absorption, bioavailability. It has to be taken after food, ideally with in an acid pH. Or so there are a lot of things about this medication, and I would say that cardiotoxicity is something that a lot of people are not aware of, especially if it's an elderly patient. Cardiotoxicity is an issue, and I would say that heart failure is a definite possibility, and especially in doses greater than 400. Nowadays, we have a lot of patients on 400 milligrams easily. Up to 600 mg is permitted, but again, it's controversial. They say that if you go beyond 100 mg BD, there is no big gain. But in practice, currently, 100 mg BD does not work. 200 mg BD works. So, I would say that we should be aware of all the things, hepatotoxicity, GI issues, and we should know the contraindications. Of course, in pregnant patients, it's teratogenic, and we need to be aware of not only the contraindications, the side effects, and the drug interactions. It's very common for many of our patients to be taken on multiple medications. We know that diabetic medications, hypoglycemia is a very big issue if you combine itraconazole with oral antidiabetic agents. And monitoring it, technically you need a trough level of itraconazole. Where do we do it? I don't know anywhere here that we can look at the blood level of itraconazole. Therefore, we are actually in a situation where we need to look at many things. Very fast I will go through this. Steroid modified tinea. Yes. You can see the side effects. It affects the palms also. They said that tinea glabrata, that means it's not palms and soles. Believe me, the fungus is moving much faster than us. It does affect the palms. Look at this. Would you ever think of tinea in this case? No. I thought of all sorts of things, rosacea, allergic contact dermatitis and all that, but look, if you look carefully, you can see. Laterally. And the ear sign, there is something very interesting about the ear sign, we'll come to that. You see this, again, a steroid modified tinea. The difference in the terminology is modified means you can still recognize in some cases that it is tinea. Incognito means it's totally unrecognizable. So, all these are very common. The unilateral ear sign. If one ear is showing inflammatory scaly patch and the other ear is okay, it is tinea. So, this is a very, very interesting thing. Unusual presentations. I never thought this would be dermatophytosis. Hyperkeratotic plaques, I was thinking of psoriasis, I was thinking of lichen planus, I was thinking of eczema, but the biopsy showed it that it was a dermatophyte. So, again, pseudoimbricata, waves of lesions, and again the hair penetration test is negative. If you find the hair going off, it's unlikely to be Trichophyton indotineae. Indotineae doesn't affect the hair. Again, a clinical sign to tell us that this is indotineae. This is not Trichophyton mentagophyton, this is not Trichophyton interdigital of other types. So hair is invariably spared, though you find inflammation, though you find big pain, though you find burning, though you find pustulation. Why is there pain and pustulation as compared to rubrum? It's a geophilic bar, zoophilic fungus which has adapted. There still are characteristics of its zoophilic nature and geophilic nature enough to produce inflammation. Therefore, it's a painful burning condition and not just itchy. Contamination by fomites, use of topical antifungal combinations, again ring in ring appearance, rosacea like presentation, a Lebanese chef. It is global. I can show almost all races. Look at the palms. Of course, dermovet is global. All over the world, people misuse dermovet. Everywhere, a Filipino patient. It's truly global. Again, a representation to say that what starts in the groin spreads to the genital area, spreads to the lips, spreads to the nails, spreads to the face. It's by contamination. Steroid modified. It's not just topical steroids. Look at this guy. He's been taking Decathlon syrup. He ended up with Cushing's syndrome. Of course, husband and wife. This is interesting. Like I said, in the older Tinea, there was a genetic element. The husband, if he gets, the children might get, but the spouse rarely got it. But nowadays, that's not so. We find that the entire family picks it up very fast. Multiple fixed drug combinations, drawstring. Obviously, there is an element of fomites. See the usage of drawstrings and how that helps spread it. Again, when you find a facial dermatosis, please look at the groin. It's invariably easier to diagnose in the groin. Again, the ring in ring appearance. Look at where this guy is keeping his cell phone. And look at where it goes next. From his bum to his face. And look at the tinea spreading. So, believe me, it is very important for us to think of tinea in any facial this one. Rosacea is no longer confined to the face. Red scrotum or rosacea of the scrotum is something very common. And ring in ring appearance. And look at the areola. So, the place where it comes on first is usually the groin. Do the apocrine gland secretions have something to do with it? Why is it that the hair penetration test is negative? Why is it that the areola is affected? So we are ill-equipped for the dangers of fungal infection. This is my core message. And we are going to see a need for new agents. A lot of new agents are there. Voriconazole is actually not licensed by FDA for dermatophytosis. But then we have nothing. We can't cure our patients nowadays. If somebody with a dermatophytosis comes to me, I tell them I can't promise that you'll be cured. I have a patient who's 35 years suffering from this and not getting cured. So we are actually looking at a desperate situation. Voriconazole was developed from fluconazole and rendered more, it can be used in multiple fungal infections. That's the main use. And again, it affects the ergosterol, and you can see that the indication and the dose 800 mg the first day, then 200 mg BD for 13 weeks. 80% cure rate has been noted in some studies. And adverse reactions include visual disturbances, fever, rash, hepatic abnormalities, nausea, vomiting, abdominal pain. We need to know this molecule also. We need to know the side effects, the contraindications, and we need to remember that the huge list of drug interactions with voriconazole too. Antifungal stewardship is very important. It's a double-edged sword. If you start using voriconazole indiscriminately, maybe it will become resistant to that too. And this is better reserved for more serious systemic infections. But we are desperate. We are in need of some kind of medication which will actually help us. Obviously, humans are part of the ecosystem, and fungi are showing that they are more intelligent and more adapted to the current environment than us, and they are moving much faster. And look at so many creams used. and look at this rare case of Tinea pedis with Tinea of the toenail, Trichophyton, indotineae. It can come anywhere. It is changing rapidly. It's no longer just crurus corporis faciae. And one of the most important things for us is to recognize this global beast which crosses borders without a visa very easily. And the fact that it is moving faster than our responses to it, new diagnostic and new therapeutic era is needed. Actually, we need to take action. All these fixed drug combinations and topical steroids should be more controlled. They are being sold indiscriminately. Even if you open Amazon, you can order the best antifungal agent you want. It says that betazole. So, I'm not against any company. All that I'm saying is we as dermatologists have a huge responsibility to society, and we need to educate and we need to make sure that rampant misuse of topical steroids and topical fixed drug combinations should be stopped, and we need to set up research institutes for dealing with dermatophytosis, and a huge opportunity is there in front of us. With that, I would like to conclude.